Our next speaker, Lin Chang, is a professor of medicine in the Division of Digestive Disease at UCLA, co-director of the Gail and Gerald Oppenheimer Center for Neurobiology of Stress, and an investigator on the center's NIH Specialized Centers of Research grant studying the role of sex and stress on brain-gut mechanisms underlying IBS. Lin wears many hats. She's also the program director of the UCLA GI Fellowship Training Program and the director of the UCLA Digestive Health and Nutrition Clinic. Her clinical expertise is in functional GI disorders, and her research focuses on the pathophysiology of IBS related to stress, sex differences, genetic factors, and neuroendocrine alterations, as well as the treatment of IBS. She'll be speaking to us about IBS, new therapies. Is there hope down the road?
Thank you, Terry. Good morning, everyone. Okay, so we all know that IBS is a heterogeneous condition which is multifactorial, and if you look at any clinical trial, only a subgroup of patients will respond to that treatment. It's probably the way it's always going to be, and you probably have to use also multiple modalities to actually improve symptoms. So we really want to get at how do we predict who's going to respond to which treatment. And I think that's why it's important to have different treatments with different mechanisms of action to help us in taking care of the patient. So I'm going to tell you about some of the therapies that we have available now and some of that are coming down the road. I have to move over here. Okay, so I thought this would just be a nice slide to show, and it's a little more simplistic, but if you're trying to target, so I always try to think, what do I think the mechanism by which that patient has symptoms? And then I try to institute treatment based on the mechanism that I think is predominant in that individual. So this is simplified, but if you think it's more of a motility abnormality or visceral hypersensitivity or more psychosocial factors that are driving the symptoms, then you would consider these different treatments. Now, it doesn't really matter sometimes what your bowel habit subtype is, but you know it's much easier. I think a lot of the treatment has been targeted on normalizing bowel habit because that's a much easier target to reach. It's much harder to resolve abdominal pain, but at least that might help in some of the symptoms. But the key with IBS is that you can have pain or this enhanced visceral perception even if you've normalized the bowel habits. And so that's something to remember. And so that's much harder to get at. So this is what I was going to touch on today, and I know we don't have that much time, so I didn't include everything that is in the pipeline. But I wanted to talk about diet because there's a new paper that I just wanted to tell you about. For IBS-C, there's recent updates on linaclotide, plecanatide, tenapanor, and for IBS-D, there's an update that I want to give you on rifaximin, a new medication called Eluxadoline. There's also a new peppermint oil over-the-counter preparation, saccharosidase supplement that's also available, and oral bovine immunoglobulin, and then a recent study on the histamine 1 antagonists. So everybody already knows about the low FODMAPs diet, which is fermentable oligosaccharides, disaccharides, monosaccharides, and polyoils. I'm sure that most of you have tried your patients on it, and there is efficacy that's been shown in controlled trials like this one in Australia, where they did a crossover study, the Australian diet being higher FODMAPs and then a low FODMAP diet. And you can see on the left that the patients on the low FODMAP diet that's shown in blue had lower GI symptoms, where in healthy controls you don't see much difference compared to the Australian high FODMAP diet. Now, there's a recent study that was done in Sweden where what they did is they compared the low FODMAP diet to the NICE guidelines. So these are national guidelines on what is a traditional diet for IBS. And what you can see is the traditional diet was 3 regular meals a day, tried to make the patient not overeat, not really fatty foods, don't get too hungry, and then you try to reduce alcohol, onions, coffee, chewing gum, beans. So you're really reducing some high FODMAP foods. So in a sense, it's a little bit of on the lower FODMAP side. But what they show here is that they didn't see any difference in the IBS symptom severity with a low FODMAP diet and a traditional guideline diet for IBS. So I would say that was interesting. and this is for 4 weeks. So if you don't have access to a GI dietitian like we do with Nancy Jaffe, and the patient isn't quite sure how to do a low FODMAP diet, if you give them some of those recommendations, their symptoms can get better. Now, there's going to be some new data at the DDW this year where it shows some efficacy of the low FODMAP diet to this type of traditional diet, and I think it probably depends on how you're determining that a patient is better. They use an IBS symptom severity scale, but you could also use other primary endpoints. So as you know, there's 2 FDA-approved medications for IBS with constipation. We have linaclotide and lubiprostone. They both have 2 doses, but what's interesting is both are approved for IBS with constipation and chronic idiopathic constipation. But the way it works for linaclotide is you have the lower dose, 145 micrograms for chronic idiopathic constipation, and you have a higher dose for IBS-C, which is 290, but lubiprostone, it's reversed. You have the lower dose, 8 micrograms BID for IBS-C, and the higher dose, 24 micrograms BID for chronic idiopathic constipation. But I will say that I think you can use either dose. Often I just start at a lower dose and then I move up because a lot of IBS patients have side effects, and I'd rather use a lower dose, or if I'm transitioning them from one type of treatment to the other, I'll transition by using a lower dose and then getting them off what they were on and then raising the dose of the other drug. So, but we do have 2 different doses for both drugs. But I want to tell you some new information about linaclotide. So linaclotide, as you know, is a guanylate cyclase C agonist. It works in the periphery. Most of it is not absorbed, and it works on the GCC receptor. And what it does is it increases cyclic GMP, and then you increase chloride secretion, sodium, water follow. Also, the cyclic GMP is thought in animal studies to decrease firing of these visceral afferent nerves. So the mechanism by which they think it helps abdominal pain as well. So you probably know the linaclotide data. I think the important point about linaclotide, if you look on the left panel, it can improve bowel habits pretty quickly. But on the right panel, what you see is to reduce sensitivity, whether it's abdominal pain or bloating, takes longer. So you're going to see the maximal effect at 8 to 12 weeks. And the patient needs to know that because they may be thinking that they're going to have reduction in their pain and bloating much more quickly than they will. I mean, to some extent you will if you improve their bowel habits, but really to maximize it, you have to be on it for 8 to 12 weeks. And that's why you want to use a lower dose. Make sure they don't get diarrhea because that is an important side effect that patients will report. So I'm going to tell you 2 new things about linaclotide. So the FDA has now recognized that you can give linaclotide in a different formulation. And I've actually been doing this in clinical practice, but now there's some guidance by the FDA. So if you want to change the dose of linaclotide, like say they have diarrhea, you want to use a lower dose than the 145, or you want to use somewhere in between 145 and 290. What you can do, or the patient doesn't like swallowing capsules, you can open up the capsule and put it in some water to dissolve it. The minimum amount of water you need is 2 tablespoons of water, but you can do a little higher. You can put a little styrofoam cup. So you open up the capsule, and the medication is coated on these granules. So you dissolve it, rapidly dissolves. They say by the FDA you have to swallow the granules, but you actually, I don't think, really have to because the medication gets rapidly absorbed in the water. You can also put it on applesauce as well, so that you can just sprinkle, and you can even put it through a G tube or NG tube in patients that are hospitalized that you need to get their bowels moving. So that's something that is new. I used to always tell patients put the other half of the cup if you want to use a lower dose in the refrigerator, but the FDA actually says not to use that at a later date. The other point I wanted to make is that there is some data that a lower dose of linaclotide, and that's 72 micrograms, has been shown to be efficacious in over 1,200 adults with chronic idiopathic constipation. This is not in published form yet. This trial was recently completed, so you can see that the 72 micrograms, so that's half of the lowest dose that we have available now, and it was shown to be efficacious by the primary endpoint in constipation trials. So I will tell you, for constipation trials or diarrhea trials, you're looking at bowel habits. If you look at IBS then you're looking at a combination of pain and bowel habit change. This is looking at complete spontaneous bowel movements, which is a common endpoint we use because it's both a motility type of endpoint and a sensory. So you have a spontaneous bowel movement, but you want to feel completely evacuated. So that's partly a sensory endpoint. But it was shown to be efficacious at this lower dose, and they used the 145 micrograms just to show the validity that these patients were getting better as well on this medication. So this is something to know. So I want to point out this figure. These are the different channels in the epithelial lining. So we talked about the CFTR channel, which is the primary chloride channel, and that's where linaclotide works. And also there's another agent that's being studied, very similar to linaclotide, called plecanatide. That's a natural analog to the GCC. And then we also have tenapanor, which works on the sodium-hydrogen exchange. It's a sodium transporter. It reabsorbs sodium, and this medication will block it. So this is the mechanism of action that these two drugs have, both for IBS-C that I just wanted to tell you about. So plecanatide increases the complete spontaneous bowel movement frequency versus placebo in IBS with constipation. They've also studied it in chronic constipation and have shown efficacy. So here you could see the different doses, the increase from baseline of the complete spontaneous bowel movements per week. And so you can see there's efficacy with the 3 milligram and the 9 milligram. There was some incidence of diarrhea, but I think it's a little bit lower than what you've seen with linaclotide. This is tenapanor, the sodium hydrogen inhibitor, transporter inhibitor, and you can see the primary endpoint, which again, in this study was complete spontaneous bowel movements. And usually what you're looking for is an increase of 1 compared to their baseline. If you look at the secondary endpoints in the middle and on the right, it's abdominal pain relief, and we usually look for a 30% reduction in abdominal pain. And on the very right, it's a combination of the bowel habit change and the abdominal pain change, in which you can see that it did reach its primary endpoint, and it was statistically significant. It was actually a wide therapeutic range, but when you do a larger study, this is a phase 2B. When you do a phase 3, usually that therapeutic gain is reduced. So we'll see in larger trials if it's efficacious, but that's one that has potential. These were the side effects. As usual with any drug in IBS, you're going to have GI side effects as your main side effect. Okay, so I'm going to move to IBS with diarrhea. You're probably familiar with the rifaximin retreatment trial. This is Target 3. This is a confusing, I know, complex study. So what they did is they recruited IBS with diarrhea patients. You had to had a certain level of symptoms, and they put everybody on placebo first, which I thought was pretty smart, but the patient didn't know it. And they took out placebo responders. And then they put them on rifaximin. They also weren't sure if they were on rifaximin or not. And some patients actually responded and had to maintain the response. But some patients then during their maintenance phase of 18 weeks would actually have a reduction, they would have a relapse of their symptoms. If they had a relapse of their symptoms, they went into their first retreatment or their second treatment, and they got randomized placebo and rifaximin. Then they followed them and watched their symptoms. Whether or not they responded or not, they went into a second retreatment for rifaximin. So that's 3 treatments, 2 retreatments. So this is the efficacy on the repeat treatment, and what you can see for both of them, it's pretty similar. The rifaximin, even in the initial trials, had about a 10% therapeutic gain. This is about the same. As you can see, it's a little on the lower side, and the reason probably is that the patients in their first retreatment and also their second retreatment, they had less severe symptoms than when they initially came into the study, but they still went through the trial. So you're probably going to see less efficacy. So this is Eluxadoline, and the mechanism of action, it's a locally active mixed mu and kappa opioid agonist. It's also a delta opioid antagonist. So the delta opioid receptor actually interacts with the mu opioid, and the thought was that if it does that maybe you would have less constipation, because this is a peripheral opioid antagonist, similar, like the mechanism of action of loperamide. But the mechanism is thought to, by which it works, is to slow GI motility, reduce visceral sensitivity, and to reduce intestinal secretion. So this is the data on the phase 3 clinical trial on the efficacy. There's 3 treatment cohorts: placebo, 75 milligrams BID, 100 milligrams BID. And the efficacy, as I said, for IBS is a combination which the FDA requires. It's a composite endpoint that you have improvement in abdominal pain in the same weeks. You have an improvement in your stool frequency or consistency. For this trial, for IBS-D, they use consistency. For IBS-C trials, they use frequency. So this is the data. There were 2 trials, and you can see there was a little bit more efficacy in the second trial. These are all multi-center trials. It was statistically significant at both doses, the 75 and the 100. It was FDA approved for both doses. Okay, so the issue also that you have to keep in mind is the side effects. So there were a proportion of patients that had adverse events and serious adverse events. And the ones that you want to think about is this 13 patients who had sphincter of Oddi spasm. So those patients who had abdominal pain, this was adjudicated, and they had elevated liver enzymes, and they were thought to have sphincter of Oddi spasm. And so 11 of those individuals actually had their gallbladder removed. And we know that by the mechanism of a peripheral mu opioid agonist that you may cause this kind of spasm. So that's something to keep in mind. There was also some cases of pancreatitis. In some of them, they had a history of alcohol abuse. So that's also something to remember as well. And this is, the data tells you why the FDA has these certain recommendations that I'm going to go over here. So the recommended dose is 100 milligrams BID with food. The recommended dose of the lower dose, which is 75 milligrams, is in patients who don't have a gallbladder, just because they may be more predisposed to sphincter of Oddi spasm, if they're not able to tolerate the 100 milligram dose. If they're receiving a medication that works on the same type of enzyme where it breaks it down, so you'd have to look up those medications, and if they have mild to moderate hepatic impairment. You want to discontinue, of course, if any patient has severe constipation. The important thing also with this one is if you miss a dose, you're not supposed to take 2 doses together. So you want to make sure that patient doesn't do that. The chance of abuse or having a feeling like you're drunk would really be if you're using very high doses. So you don't want to you don't have the patient double up their dose, but it really occurs in less than 1% of individuals based on the clinical trials. Okay, so there is a new over-the-counter remedy, which you may know of, and there's data and meta-analysis to show that peppermint oil, which works as an antispasmodic, can be helpful with IBS symptoms, particularly postprandial symptoms. So this preparation was made because it wanted to target it to be absorbed in the small bowel and not in the stomach, thinking that it would decrease heartburn. So this is a small study presented at the DDW last year. So only 35 in the peppermint oil group, which is IBGARD, and then placebo, 37, IBS diarrhea and IBS mixed. And so it was 4 weeks of treatment, and they used a different primary endpoint. They used a total IBS symptom score, which was a 5-point scale, 0 to 4. So I just try to summarize this data on a modified intention to treat analysis on some of the symptoms. They looked at frequency of symptoms and intensity of symptoms. So you can see that it did improve compared to placebo. The intensity and frequency of abdominal pain or discomfort. It also reduced the intensity of bloating. It didn't really change bowel habits. So it's something for you to think about trying in your patients for particular postprandial symptoms. It comes as 1 and 2 capsules, and the study used 2 capsules 30 to 60 minutes before a meal. So it might be something you try in your patients that maybe if 1 capsule isn't good enough, you would use 2. There's also some data that sucrase isomaltase deficiency, which we see in children, and it's genetically based, that maybe it is actually the cause in some of the adults with IBS with diarrhea. So that's an area that's being studied right now. We really don't know if you take a whole group of IBS with diarrhea patients or functional diarrhea patients, how many of them will really have the sucrase deficiency? But there is a saccharosidase enzyme replacement called sucrase that is available for you to use. It's derived from Saccharomyces cerevisiae. And it comes as a supplement, and you can use this, and it has shown some efficacy and safety in children and adults with this saccharosidase supplement. but it's going to be studied more in IBS diarrhea, so hopefully we'll have more information to give you. And there is a way to detect it, and there's different ways that you can find out. We could talk about it later. In the interest of time, I'm going to keep going. So there is serum-derived bovine immunoglobulin and protein isolate. This is called Interrogam. This comes as packets, and it was a company that I think it's based, it lives, in farm country, so they have a lot of access to cows, and take all the serum from cows and found out there's a lot of immunoglobulins and protein, and developed this medical food. Okay, so a medical food doesn't have to go through as quite a stringent analysis and review by the FDA, but it still has to be evaluated. But this has been prepared for potentially improving symptoms of diarrhea in HIV, inflammatory bowel disease, and IBS with diarrhea. It hasn't been studied that much, but they do have a pilot randomized controlled trial in 66 IBS diarrhea patients. You could do a packet once a day or a packet twice a day, and it showed that it did decrease some symptoms in patients. I probably use it only for a month if you want to see if it helps, but they do give samples, and it's something that you have to write a prescription for, but it potentially can improve symptoms. The thought is that it helps improve the intestinal barrier that may be more porous in patients with these chronic conditions, and also help the immune system as well. There's a new study that just got published on an H1 antagonist called Avastin in IBS. So, there's been a lot of data, and this is somewhat conflicting, that mast cells are increased in the mucosa in IBS with diarrhea patients. Some studies show it's present, some show it isn't. But it's thought that mast cells, when they get degranulated and activate, they're going to release tryptase and other mediators and proteases that are going to act on these sensory afferent nerves, cause them to trigger and excite them, and cause them to be activated, and you get motility changes and visceral hypersensitivity. So this study done in Leuven by Guy Bockstein, and they have shown in a previous study that ketotifen is a mast cell stabilizer and H1 antagonist, and that improved visceral sensation in symptoms in a small number of patients, only 30 patients. But it's thought that the histamine, like I said, can activate these visceral afferent nerves by activating on the TRPV1 receptors. So they did a study in 55 IBS patients, and they randomized them to Avastin or placebo for 12 weeks. And you can see the data here on the slide. And it showed that more patients treated with this H1 antagonist versus placebo had considerable relief in symptoms. Now remember, this is a small study. There was no difference in other GI symptoms on a type of questionnaire that they used there, and the IBS quality of life score did show some improvement. And we use sometimes cyproheptadine. It's used in children. It's called Periactin. But this is very similar to like a Benadryl type drug. And some think that by using these H1 antagonists that you can reduce symptoms. But I think we'll have to see in the future if that's the case. So the summary of available treatments and future treatments. So treatment decisions are really based on your patient's symptoms. What did they use in the past? What are they interested in using? What's their motivation and your clinical experience? You try to the best of your ability, take all the factors in mind and try to predict what the best treatment response will be for them. But I usually give them a different variety of thoughts, because I think when they get to us, they're worried that I actually had one patient who said that she wouldn't take the medication I prescribed because I was the last person that she was going to be able to see, and if that didn't work, then she didn't have anything else. So I don't want people to do that, so I just kind of give them a menu of things, and then we decide together what's the best. So IBS-C, there's Cilium, of course, lubiprostone, linaclotide, PEG, which can work very well. IBS with diarrhea, there's diet, anti-diarrheal agents, tricyclic agents, antispasmodics, rifaximin, Eluxadoline for severe IBS diarrhea with women, and then now you have Eluxadoline or saccharidase supplement. IBS mix, there's not many studies. There's very, very few, but you use a combination, and I think it's always easy to target the constipation so they don't have the day of diarrhea. Pain predominant, you think about antispasmodics, particularly postprandial pain, antidepressants, and psychological therapy that's shown to be beneficial. Bloating is always the toughest. Dietary changes, rifaximin, probiotics can be considered. And for all subtypes, you always want education, reassurance, and behavioral therapy. So thank you very much for your attention.